In this episode, we head over to the Hilton Garden Inn and host our very first menopause event, the M Factor Watch Party with Premier U Telemed.
I know you're clinging to the light of day, to tell you everything's A-okay, and medication don't do much. Yeah, it just numbs the brain. Guess you might say I'm a little intense. I'm on the bright side of being hell-bent. So, take it from me, you're not the only one who can't see straight. If you were ever in doubt, don't sell yourself short. You might be bulletproof. Hard to move mountains when you're paralyzed, but you gotta try. And I'm calling out, get up, get up, get a move on. Get up, what's taking so long? Get up, get a move on. Stop stalling, I'm calling out.
All right. Welcome to the very first ever M Factor Menopause event in Springfield. This is not the first one, but this is the first one we've ever done here locally. For those of you who don't know me, I'm John Gorman, one of your hosts today. This is Shannon Shores, and you've really been instrumental in bringing this to the forefront. You've done 2 of these, so a lot of you know me and what I want and what I do. What I want to do is have you introduce yourself and talk about what the M Factor event is and what we're about to see.
Sure. Thank you, John, and thank you for the rest of us hormonal women. Turn on the AC. Everyone just feel that, right? Thank you, Renee. As you said, my name is Shannon Shores. I am with Premier U. I get to do business development and marketing. So I get to go around and hype up the amazing providers that we have. Jordan Kimbler, who you'll meet afterwards for the great conversation. I get to work with Brandon Williams on the daily. And you know what? When he gets up and he talks, he's got a lot of big words, but really he knows every quote from every silly movie out there. So just test him and he might really surprise you. M Factor means a lot to me. Tamsin Fadell brought this documentary with PBS, over a year ago, because what she found out being an anchor on the news is that women are going through this and no one's talking about it. She's having a hot flash while she's doing the 5 o'clock news. Are they going to stop and be like, hold on, let's have a moment while Tamsin goes through this? No, she's going to sweat through her things and she's got to keep rolling on. And what she realized is that we all women were starting to have things younger and younger. We thought menopause was like your grandma's menopause, clutching our pearls, just trying to get through it. And we don't have to do that anymore. In my early 40s, started to have symptoms, started to have hot flashes. I was going into an event for my son, and I thought I was walking through the Sahara Desert. And anyone who's had one knows it's that internal heat you can't turn off. And people's like, oh, cool off. It's like, no, I want my skin off me now, right? And I went to go see my OBGYN, and she said, gosh, this could be perimenopause. And I said, Perry who? Who invited him to this party and get him the hell out of here, right? And she said, oh, sorry, you could do this for the next 10 years. High five, good luck. And I left going, oh God, is this what aging looks like? But aging doesn't have to. It wasn't until I found people at Premier U. I was starting to do this before I started to join a brand that was so magical to me. And I get to empower women like you and men, supporting yes, thank you, yeah. Supporting her through this, but that's what we're doing. We're giving resources. Jordan and I just spent this weekend. This is our second leg of our trip this weekend. We were in Innsbruck for a leadership conference and empowerment, so we are really feeling very hyped up right now. But we met with women, and they thought, I don't have to live like this. I can sleep. I don't have to be full of anxiety. What the heck? And we did a really great job, Jordan especially, talking about women's resources. So I love that the M Factor is a place for you to see through this, and afterwards you're going to go, I never thought about it in that way. So I'm here. I'm very thankful, and thank you, John, for letting me be a part of this conversation.
Yeah, so the cool thing is, since I'm an uncomfortable man up here, all you guys raise your hand in the room real quick, if you would. Okay. This is important, and for this reason. This is going to be my 3rd time watching this.
Yes.
every single time I watch this documentary, I learn something massive. So I have a lot of clients in the room, a lot of coaches that I work with. We learn so much as guys about how to, whether it's your spouse or whether it's a client that you're working with, if you're a coach, what these phases are and how they're important. It's probably the most important thing I've ever watched in the industry. So I'm really excited for everyone here to watch that. So here's what we're gonna do. We're gonna go ahead and turn the documentary on. It's about an hour. And then afterwards, we'll take a 10-minute bathroom break, and then we'll sit up here and we'll introduce everybody and we'll do the Q&A panel. So everyone's good. We're gonna go ahead and start the movie. All right, this is going to be a blast. I love Q&A panels. We've all done this a zillion times. This is really where we all learn a ton. All right, so Jason Wells is back here. He's raising a hand. He has the mic, so if you have a question, raise your hand. He'll pass that around to you. And no question is a dumb question. I'm telling you, this is the time for everyone to learn. I also have a bunch of questions that were sent in to us that we're also going to read off. So we've got these here. What I want to do is introduce people on our panel. So first of all, Leslie's not here. Most everyone here knows Leslie. Family emergency, everyone's fine. She's had to be caretaker for the day. So I got to tag in my tag partner over here, Renee, who is, I'll just start by introducing you. So you'll notice on the panel, we have medical practitioners, and then we've got coaches and trainers. So Renee and I are going to cover things like supplementation, diet, training, and most people know me. I have a lot of experience in that, and Renee is one of the most sought-after trainers in the industry. She's been through it as an athlete. She's got a ton of clients as a coach that are women. She understands menopause, and she's been through training, all kinds of different courses. So she's the perfect person to jump in here and cover this in Leslie's place. And then finally, over here, and then I'll let you do the rest of the introductions, we've got Dr. Greg Reeder. Now, the cool part of this is we go back to 2014. We worked together. I was his coach. He got on stage, but he's a doctor. This guy can deliver babies in his sleep. Matter of fact, you probably delivered a baby on your way here. You're just that good.
We're past that.
Yeah. Dr. Greg is who Leslie and I started learning from in 2014 because she started to have some issues with hormones from dieting. And I didn't know anything about hormones. Leslie knew nothing as well. He brought her in and we started learning about labs and what different things were. And over the years, some of you here have worked with Greg. Some of you have traveled and you know Greg. Over the years, I sent all my female clients to you before we started Premier U Telemed. So for the last it's 11 years now, you've been helping my clients. So when Brandon and myself and Dr. Greg, who's not here, he's in St. Louis, when we start Premier U Telemed, I knew immediately, I was like, guys, we have to get Dr. Greg on the team because he's just so awesome. So that's my introduction of these two and myself. Shannon, if you would, introduce the rest of everyone.
Okay. This could be fun. All right. So let's start with Brandon. I think by just looking at I was looking at the bio on Premier U, and it's true to say, by looking at Brandon, you can tell that he lives the Premier U lifestyle through the way that he teaches us, through the way that bringing in different services for us and challenge us to be our best selves. He truly is the epitome in living the life of the Premier U. Definitely in all three of our locations, adding the telemed on, we look to Brandon to bring us the latest and greatest. And like I said, he's full of a lot of knowledge, but he can be a lot of fun too. When it comes to, the one-liners and things like that. I know I feel very blessed that he trusts me with his business every day, even though I can be just as silly sometimes with him. And I think as we come from our women's empowerment, when I met Brandon and Greg, not that Greg, but the other Greg who's not here today, they said, we need to have you on our team. And I said, you don't want me? And they said, why not? And I said, I'm bossy. and I'm really expensive. Now, Brandon would probably agree to both of those things by now, right? Because I know my worth times tax. Women in the room, know your worth, add tax. But I really feel very honored to work with him every day. And speaking of honor, Jordan Kimler, nurse practitioner with Premier U. This is who, if you've gone through Telemed, you're seeing her and you're in great hands. She makes my job as business development so easy, because not only do you see her living the life, she's gone through her own journey. She's also lost 50 pounds and she's kept it off. And when you look at her, you go, make it look so easy. But she's very transparent. She's so real about how she does it and how she's living that Premier U lifestyle every day. So I'm blessed to be a part of this, and I'm glad to be in front of you for this Telemed. And who's going to be the brave soul to ask the first question?
Well,
sorry. He didn't want me to take the mic for too much longer. Here we go.
I actually have a question, but before I forget, stand up in the back. Miss Nicole, go ahead and stand up. Everyone knows Nicole. So because she's not on the panel, I didn't want to miss Nicole. She really is the lifeblood and the heartbeat of the Telemed side of things. So everyone that has contacted us, you've gone through Nicole. She was a perfect person for us to add. I just wanted to say she's going to be around, because there's going to be people who want to talk afterwards and still have more questions. Make sure you grab Nicole. So, and then finally, my last question is for you. So if you look on the desk, I did not know that you were bringing these. I don't know how many people got these. There's this sticker that says Cougar Puberty. Oh, honey, we're just getting started. Tell me we're going to put that on a shirt and make millions.
Yeah. Well, some of you got, that's Heather on this one, who's a PA in our Swansea. And some of you got Jordan, and it's the best AI I could pull looking for her. But who has heard of the term Cougar Puberty? Okay. And some of you who haven't, who's the ones who hasn't? Hi. Okay. All right. So let me explain this to you. Cougar puberty. Remember when we were going through puberty and we started getting like leg hair and that armpit hair? I remember being in this swim class like, Mom, what am I going to do with this? She's like, you got to wait till you're older. But anyway, so we started getting that hair. Now I have just as much hair on here that I have here, right? That's puberty. My body odor is starting to change. I was wearing clinical deodorant for years, and all of a sudden, that clinical deodorant ain't even touching it anymore, right? And so we change just like puberty. So the reason why in that packet, not only do you get the cute little sticker to put on things to have a good giggle, and we put on t-shirts, lights out, you're right. You have a little mirror and you have tweezers, because ladies, can I get an amen that all tweezers are not the same? Amen, right? So I got you the mirror and the tweezers so you can get the chin hairs, and real friends tell other friends when they have the chin hairs, right? Okay. Now can I ask, who is the right person to ask the first question?
I had my annual visit with my gynecologist this past year, and I'm on Mirena IUD. I'll be 38 next month. And the doctor was like, I asked, I should probably look at getting this taken out because I'm nearing 40. I've heard risk of cancer going up. But then she said, you know what? I've had a lot of patients, and I encourage them to leave it in because it helps to mitigate any perimenopause, menopause, and you just breeze right through things. You'll have less symptoms. So it was, okay, you know. A lot of it is looking online, and you never know of, like, trust but verify. Of, like, I have no idea, and I can't find a lot of information about it. So as far as, do you stay on an IUD and get it replaced, or is it like, I don't know. It's like, also it's with physique goals, you hear a lot of things, because I do bodybuilding, of getting off birth control is better for physique enhancement. So it's like I'm kind of stuck between what's the right thing to do for my personal goals and health.
Sure. So I'll take it first, and then I'll pass it to Dr. Gregg on his standpoint. But ultimately, from my standpoint, I do see that women that experienced heavy bleeding, and especially sometimes that can increase right before menopause, that it does help where it kind of keeps iron stores up, things like that. So in that way, yes, it does help women transition a little bit easier into menopause, and that may be where they're coming from too, which I'll let him speak on that. I always say kind of favorite form of birth control is a vasectomy for the men in the room. And then Shannon's really kind of pushing me towards talking about taking control of your own body, having your tubes, tied, things like that, taken out. But what I always say is that the progestin is going to protect the uterus, right? But you're not going to get the neurocognitive benefits like you do from like oral progesterone. So.
Well, let's explain what Mirena is for some of you that may not know. It's an IUD, intrauterine device, T-shaped device with a little string on it so it can be removed easily. It's placed during a pelvic exam. It takes less than 5 minutes to put one in. It's a progesterone-containing device. Initially, they came out lasting about 5 years, and then I think it went to 6, 7. Now it's up to 8 years that it can be left in place. It does not inhibit ovulation in every woman, but in a large percentage of women it does. So they become amenorrheic, which means no periods, which is a great benefit to the IUD. It's low dosed. It's a long-term reversible birth control. I've had a lot of patients that remove it, and within the first cycle they're pregnant, and that first cycle can come within a couple of weeks. So it's very low dose, safe while you're breastfeeding. It's been around, I've been putting them in for probably 23 or 24 years. I'm in my 29th year of practice. And before that, we had a copper IUD, which is still out there, a 10-year IUD with no hormones. But my experience with those is that people have extremely heavy periods. So when Mirena came out, we had a low-dose hormone that inhibited the endometrial lining, kept it suppressed, inhibited ovulation. We didn't cycle. And it could be left in for 5 years, and at the end of the 5 years, a lot of ladies would come in with a great experience, have it removed, put it back, a new one back in. Now it's up to 8 years, and we're doing the same thing. We're leaving it in even into the menopause because it protects the uterus, and I can add estrogen without adding a progesterone because they already have that on board. So if they have a uterus, we want to have something that protects the endometrial lining from turning into hyperplasia or complex hyperplasia, atypical hyperplasia that turns into cancer. And so the IUD does that, and I can add estrogen to hit the vasomotor symptoms, the cognitive stuff, the cardioprotective stuff, the bone protection, and leave the Mirena in.
Okay.
I don't have a problem with leaving them in a long time.
Yeah, that was really helpful. It just helps having other people talk about it rather than I just talk to my
You're
own.
not having problems.
No, it's been amazing. I love it.
That's what most people will say. Now, you'll have some young girls that'll get an IUD and within 3 or 4 months they're wanting it out. And
Yeah.
it's not for everybody. Sometimes they'll have significant cramping. Sometimes the placement is not optimal, and the arms will get twisted or they'll perforate a uterus. There'll be complications, but in a trained hand, you can put an IUD in about 5 minutes and walk out and they'll never know it's there.
Yeah. Thank you very much. There you go, Jason.
Thank you. Since we were talking about IUDs, I have an IUD. I'll be 50 next month. I'm not really experiencing like any sort of benefits from it for my perimenopausal symptoms, but I do like it because it does mean I don't have a period, which could be erratic right now. What do you recommend as far as like keeping it in? I know you said keep it in forever, but for somebody, you know, pushing 50, like, what do you recommend, or do you have a recommendation?
There's no real reason that you need to take it out.
Okay.
Even at the 8-year mark, in a reproductive age female, it may give some contraceptive benefits just because it's a foreign body inside the uterus, which makes a hostile environment for sperm and egg to fertilize. So there's really not any big reason. Now, I don't use it to treat menopausal symptoms. I mean, we may use it to control abnormal bleeding or irregular shedding. I don't see a reason in my practice to take one out just because you hit 50.
Okay.
Don't be ashamed to say you're going to turn 50. I mean, own it. I mean, it's just a number.
Well, I asked my gynecologist when they put the newest one in, because I hit the 8-year mark and then we replaced it. I asked him how long I could keep it, and he said, until you're 52. So I was curious what the thought process behind that was.
There is not a switch inside that Mirena that flips off.
I was like, fine.
In fact, guys, the same Mirenas that are being produced right now that are good for 8 years are exactly like the ones that were produced 23 years ago when I started putting them in.
Okay, I have a question. So this has been 6 years going for me. So when I started, when I was 50, they said that, because I don't have a uterus, and he said, my primary said, you can take progesterone. My OBGYN says absolutely not. But then when I went back to him, he said that they've been doing more studies, and progesterone, it is good for someone without a uterus to take. What do you think about that?
Anybody else want to speak?
So kind of speaking from the neurocognitive benefits, sleep, especially women are waking between the hours of 1 and 3. That's not normal, right? So it could be low progesterone related. In those patients, I will typically start smaller dose versus standard dose just to trial it. Occasionally, if patients can't tolerate oral progesterone, I will put it vaginally. I've had some success with that, but not as much orally. But to me, yes, there are benefits other than protecting uterus. Yeah.
So the OBGYN, she's and it's a woman, and she absolutely will not even talk to me about HRT, like nothing. She's like, won't prescribe it, I won't put you on it, nothing. My primary, he was like all over it. He's like, do whatever it is that makes you feel better. So, but I also work at Mercy, so there's like,
You're kind of locked in, right?
Yeah.
So like as I said in the documentary, like find someone that will,
Right.
Someone that'll listen to you. I mean, Dr. Greg, are there any reasons that they wouldn't want her to be on that?
Well, you guys have already figured out replacing hormones is not a recipe that fits everybody. It's tailored and catered to whatever their symptoms are and their physical state is in, and whether they got a uterus or don't have a uterus. But yeah, there is benefits to taking it. I mean, primarily it helps sleep. I mean, pregnant women are incredibly sleepy in the first trimester, and it's because of high levels of progesterone. So yeah, there's no reason to not take it. Now, I'll start with estrogen alone because more is not always better. There's the expense. It's another pill to have to remember. So I'll start with basic replacement and then add to it, either depending on whether it's working or not working and what we need to add. Some people are going to do great on just estrogen if they don't have a uterus. If they do have a uterus, you have to be on both. You have to.
I'm on both.
Yeah. Now, as far as I deal with this every day, I put somebody on HRT, they go see their primary care and they get told you need to quit taking that, or you can only take it for 6 years or whatever, and they pull them or scare somebody. Find a new doc. They're not keeping up on the latest literature. They're not keeping up on the latest studies. They're not watching the podcasts. They're not looking at this kind of stuff. It's labor intensive. You may have an OB-GYN that is primarily an obstetrician and not dealing with the menopause. You go to a young female OB-GYN, she's not even experienced it herself. How does she treat it? I've lived with it because my wife has, gone through the menopause. Now, the best thing about being married to an OB-GYN is she's never experienced a hot flash or a night sweat. We transitioned her because she had an endometrial ablation where we burned the lining of her uterus. She didn't have periods to tell us if she was menopausal or irregular. And so when she hit that age, before it ever started, we started on HRT. And she's got a mother who had breast cancer in her 40s. So find a new doc.
So, speaking of the scare of breast cancer and things of that nature, something big happened November 10th with the black box warning. Can you all talk about that?
Yeah, so the black box warning was removed last Monday, actually, off of estrogen products. So it's huge because I will tell you, patients that show up to the pharmacy, it may take it a while, obviously, for those to be actually removed, but how many phone calls Nicole's had to take from patients, like, is this safe to take? I know Jordan went through benefits versus risk, all of that with me. So I think it's huge for access, especially for vaginal estrogen. As I said in the documentary, essentially most patients can take vaginal estrogen, even those that have had estrogen receptor positive breast cancer. So I think it's monumental, honestly. I get kind of emotional talking about it because I would have the patient really ready to go, start their hormones. We'd go through benefits versus risk for them, and the benefits outweighed the risk, in my opinion. And for them, they'd show up to the pharmacy. Pharmacists would scare them. They would call. It was a whole thing. So I'm really, really hopeful that will help with that.
So I may be one of the oldest in here, if not the oldest. And I actually was in my 6th year of practice when the WHI came out and was announced in that summer of 2002. I had just moved from a Oklahoma practice to Northwest Arkansas, and Oprah Winfrey, I think, even had a segment on it. And all of a sudden, women were hearing or being told to come off hormones even before some of us practitioners had got the news. And the phone calls started immediately. Now, if I was kind of interested in some of that really early on and didn't buy into not treating the symptoms, and I went ahead and prescribed HRT all the way through that. It was kind of an exception. My own 93-year-old grandmother would get Premarin samples from me because she felt better taking a Premarin tablet every day. And I gave those samples to her until she passed from a stroke at 93. And I have no regret at all of giving my grandmother a product through all of those years. When she passed in, I think, 2007, we'd been given, we gave her hormones. So if you look at the statistics of the increased risk that came from that WHI, it was 0.1% increased risk. So to give you an analogy that I give my patients, if you were walking along and saw a penny on the floor, that's 1% of a dollar. A tenth of a penny is a tenth of 1%, right? A tenth of a penny is, you'd look at it and walk on by. You wouldn't pick up the penny. You're sure not going to pick up a tenth of a penny. So it puts things in perspective as to the real risk. It was insignificant. It always has been.
I just wanted to say too, so that's perfect actually about the penny, because we stopped making the penny right now. So it's a further illustration of the point. Yes, insignificant.
We're going to change that because nobody's going to know what a penny is.
Yeah, exactly. Yeah, just like we didn't know what a mite was, and they got rid of that. But I did want to go back to your comment about, or when we're talking about additional benefits. So obviously you saw from the M Factor movie, and obviously we see very often there are cognitive issues. So these neurodegenerative diseases like MS, Alzheimer's get talked about increasingly, oral health, so bone erosion, these other things that happen. Now that's more of an estrogen thing, but specifically as it relates to progesterone and the increased risk of MS and Alzheimer's that you see in females has been linked to something called allopregnenolone, which is it's a progesterone based, that is the neuronal progesterone. That switch that happens in the brain, it's a loss of something called immune tolerance. Basically, it's a shift in your brain that is pro-inflammatory. And these agents are very helpful in being able to reduce that inflammatory burden as to be able to reduce your risk of development of that. I mean, the classic example is the 40-year-old female who develops MS. There's a reason that happens. There's a reason that women tend to get Alzheimer's at an increased risk. There's an increased risk and incidence of dementia in females. Now, this is not completely explained by current science, but science is getting closer and closer to be able to understand those mechanisms. And this exact topic has a relationship with that, and being able to balance that and replace those factors that, when we talk about aging, like he said, it's just a number. And the question always is, what does it mean to age? And it means that you've lost something that kept you young. Sequentially throughout life, we are hitting these markers where we're losing the things that protect us. We lose the thymus gland when we're very young. It increasingly decreases, so we develop these immune problems. We lose, females lose estrogen, they lose progesterone, they start to lose testosterone. Guys lose testosterone, estrogen as a result, and also progesterone too. These things are the things that keep us young, that help to protect us and make us resilient when we're younger, and that's the consequence of aging, is really the change in that hormone production and basically the resilience of your cells.
So Brandon, I think this is a good segue. One question I want you to kind of talk about that I hear a lot from patients. I talk about muscle is longevity, right? So everyone in this room agrees that muscle is longevity, but a lot of my patients only understand it from prevention of osteoporosis. Can you talk about just layman's terms connection between muscle and brain?
Sure.
Okay.
I'll do my best. She knows me well.
Hey, remember, you gotta bring it down for the pros.
Oh no, that's okay. That's okay. So I just get very excited. So muscle is obviously very protected from a multitude of places. So obviously from a functional perspective and being able to care for yourself, right, to keep you out of a nursing home as we get older and elderly, that's a huge endeavor for physical therapists and occupational therapists. But well before that, and obviously through the rest of your life, it's this idea of protecting your brain and neurologically to sort of tie that in. Exercising, resistance training in particular, is very good at helping develop and protect neurons. So part of this neurocognitive, neurodegenerative problem relates to mechanisms that happen when you start to develop muscle loss, or another phrase for that, the complicated one, is sarcopenia. You're going to see that phrase used more regularly. It's basically the systematic loss of muscle over time. Muscle is our largest endocrine organ. You ask an endocrinologist, they'll tell you I'm wrong, but I know I'm right. It comprises 40% of what we are. It's also a very strong signaling organ. It's basically amplifying other parts of our body. So our cells output agents, signaling agents, those get amplified in our muscle. If you have less of that muscle, you're going to have less amplification. If you don't use those muscles, you're also going to have fewer signals to the brain, to the gut, to these other places that help you with your immune system, help to protect you from the world around you, basically. And that idea of, I'll use another large word called neuroplasticity. Neuroplasticity is basically, yes, you can develop new neurons. That happens, you have to replace them. But also you just need to protect the ones that you have and to make them efficient. And muscle is very good. It is a critical change agent in your ability to protect your nervous system. Not only just the control of your body, but also how healthy is your brain and how do you protect yourself from developing degenerative conditions.
Thank you.
Yeah.
Okay, hello. I have a question. So I have been on HRT for, we both have about 8 years now, by pellet form. And I've recently heard about doing it a self-shot myself. I don't have a uterus anymore. What are, just to remind me again, some of the benefits, if there are any, of changing from a pellet form to doing self-injections?
I think we'll all go, actually. It's going to be probably the same standard opinion. So where I struggle with pellets is I understand the appeal. I'm a busy mom of 2, opening new businesses, all the things, right? So I understand the appeal, go every 3 to 4 months, have pellets inserted. The unpredictability is what I don't love with the metabolism. I think that's super tough because every patient's a little bit different. And that's really what I would say regarding it. Now, I've had patients do very well with pellets that come to me for estrogen, progesterone, and other things. They just go to see somebody else for pellets. Currently, we do not offer those in our practice. But once again, I think too, like I don't love patients going straight to pellets. So if you've never had testosterone before, if you've never had estrogen before, once it's in, it's in. So if you're having side effects, it can be very, very difficult to try to manage those side effects. And I think Renee might have a story on pellets.
I can tell my story. It's a unique story. So I started HRT with a pellet. I went to a very well-known clinic just in my hometown because I was having symptoms of low libido and low energy, and I just didn't feel like myself. So I went, got my testosterone and all of my labs checked, and they told me that, I needed, you have low testosterone. When knowing what I know now, I look at those numbers and it actually wasn't very low. So make sure that you vet your clinic that you go to make sure that they're very credible and not just trying to sell you a subscription to a pellet. So I decided absolutely, I want to do this. I want to have sex with my husband again and enjoy it and not hurt and all of the things that happen. And so I started HRT and only testosterone in the pellet. But like Jordan, you mentioned, when you get the pellet inserted, it's in. And so I had this surge of hormones and I felt amazing. run through a wall. I could do anything, and I could get 100% like recovered from workouts. It was amazing. Started to see physique enhancement. Like, it was great. I had some side effects that I didn't know what I didn't know at the time. I didn't know what questions I needed to ask. They didn't educate me on negative side effects for high testosterone. I asked them some of the questions as I started to experience my voice changing, as I started to experience hair growth, other negative side effects as well. We're not giving you that big of a dose. It's fine. It's just all in your head. So I kept getting these supplements or these pellets. Well, what I didn't love was, I'm a gym rat, love to go into the gym. I metabolize those hormones pretty quickly. And so I would get this surge of hormones, and then it would just go and just tank, and I'd feel like shit for about 8 weeks because I couldn't get another pellet. And so the body likes homeostasis. They want it to just be nice and steady. And I just was doing this roller coaster of emotions and hormones, and I just was feeling great. And then even my husband would be like, "Is it time for your pellet?" I'm like, "No, unfortunately, it's not." So that's my experience. And then, shifting over to injections, which, the physicians can talk about more intelligently than I can. But I feel a lot better, and my body likes it a lot better to have that homeostasis. So,
in our area, pellets are more of an office gimmick for providers to make a large sum of money on a very short visit. In our area, it's about $400 for insertion, including the pellets, and those are repeated about every 12 weeks. Like it's already been said up here, once they go into the skin, you're stuck with them. Can't go in there, can't dig them out, good or bad. You're going to deal with it until it wears off or is metabolized out of your body. I understand the convenience. And when people get optimized where they do feel good, there might be a place for it. If they like the convenience, they don't mind the expense. I think all of these are going to work. Whether you get it orally, transdermally, injectable, pellets, they all work. It's just a matter of finding the dose that is best for you. Compounding pills, compounding creams are not covered by insurance. I think you guys have seen that or know that already. Testosterone in general is not covered by very many insurance companies for women. There's a few out there. Compounded pills and creams to average compounding pharmacies are going to run anywhere from probably $40 to $50. Injectable testosterone, we used to have injectables in the compounding pharmacies, but it was taken away from them because they had to do batch testing and prove how accurate they were, and it was basically mainstream pharmacies getting rid of the compounders to do it. So now we use vials, multi-dose vials. Men are using vials that are dosed in a concentration of 200 milligrams per cc or ml. We can get mainstream pharmaceutical 10 ml vials that are 100 milligrams per ml, and we can dose that down to female dosing, which on the average, a good starting dose is going to be 10 milligrams a week or 0.1 cc a week, and you can even divide that with some of the small syringes that we have. Pharmacies are going to tell you to get rid of that vial after about 2 months of use because it's a multi-dose vial. They don't want you to contaminate it by using a needle in and out of it. Back in the old days, when we kept vials for patients in the office, we used them until they went dry. And we never had a concern about a contaminated bottle if we were wiping the top with an alcohol swab and using a fresh needle. We'd use it till it went dry. And that's what I tell my patients now. Use it till it's gone. If it looks contaminated, if you have any fear, if you see particulate matter in it, something that doesn't look right, cloudy, get rid of it. It's cheap, $85 for a bottle that'll last you almost 2 years. Probably the cheapest hormone you can get is testosterone. Because you'll, at a tenth of a cc, hypothetically, in a perfect world, you'll get 100 injections out of that bottle if you're maintaining physiologic doses. Some of my ladies need 0.2. They need 20 milligrams a week to get their free level in a range that they feel good. And we're not just checking total. And we're checking the free level, which is bioavailable, and you guys can talk more about that if you want to. But injectable is definitely a great way to go. Bypasses the liver, getting past the skin. My wife with transdermal creams doesn't absorb. We spent months and a lot of money trying to use a transdermal cream. She didn't absorb it. We couldn't get her levels to move. Went to an injectable. We bypassed the skin. We're still bypassing the liver. She feels great.
And it's super duper easy to do an injection, whether it's once a week, twice a week, 3 times a week, whatever your provider tells you to do. But it's painless, just right under the skin with a very small insulin needle, and super convenient. If convenience is your thing, you don't even have to leave your house.
I just wanted to add about the pellets conversation. So I think that, so partially about when you get them and you feel this very robust change. For people that are very active, which you heard me talk already about how important that is for your neurologic system and so many things, pellets degradation is based on something called cardiac output. And so the more active you are, the higher your cardiac output will be, and you will churn through them faster. In addition, when you first start them, your body is craving those substances. It's like, yes, give me that. Give me a bunch of it. And so you can have an excessive reaction too, because something that should be titrated out over a few months period of time will come out into your system in 3 to 4 weeks. And that will cause all kinds of problems. I think that there is a role for pellets, but I think it's extremely nuanced and has to be in a situation where somebody is in what I like to call cruise mode. You've figured out exactly what their body likes. They've stabilized. They're doing all the other right things from a lifestyle perspective, meaning that they're not likely to have very large deviations in their health upcoming that you can predict anyway. And in those patients, they can be helpful. But here's probably the bigger problem, and what I wanted to add is that what I tend to see is that providers that provide pellets, not always, but usually are not providers that understand hormones. They have used an algorithm. There are very large, and I won't say them out loud, but there are very large organizations that are very popular, and basically what is happening in the background is that provider is taking labs and they throw them into computer software, and that software tells them what to do, how much hormone to put in that pellet for you, and that's a problem. Because they're not really diagnosing you, they're not creating a relationship, which is very important. And as a result, they're not going to be able to manage the invariable fluctuations that happen because of life, because of your status, your response to those hormones. And I think that's probably the biggest problem that I see with pellets. It's not so much that they're inherently bad, it's that they are not managed well. The patients are not managed well by clinics and providers that honestly know what they're doing. And that's a huge problem, probably the biggest problem in my opinion with that form of treatment.
I can add to that because in our area we have plastic surgeons that are putting pellets in. They have no formal hormone training other than what they got in med school, just like me or any other OB-GYN or family practice. A lot of them don't go to any kind of conferences. They just had somebody come by and say, this is a way we can generate some more revenue in the office. They don't follow up. They expect them to come in every 12 weeks, and most people will do it for the ones that start will do it for a little while because it helps, it works. But then they'll fall off and they're not feeling well, and then we'll end up getting them and we'll find them either way overdosed or having other problems.
Thanks. I have 2 questions. How are the pellets inserted then, and where?
So I can let Jordan answer this too, but so typically what happens is under sterile technique, there's a small incision that's placed, and then there's something called a trocar, which is an introducing instrument, is placed to put it right underneath the skin.
Okay.
Yeah, it's a small minor surgical procedure is what it's called.
The pellets are about the size of a grain of rice.
Okay.
And so they have to be big enough to travel down an instrument to get it under the skin. The device is about this long. They put a nick in the skin so they can get that in, because you know what a needle feels like going in your skin. You're not going to shove something that you can look down the barrel of without it hurting. So they'll numb it up, make a small incision, slip it under the skin, and then push the pellet in.
Thank you. And then I'm curious, I have a friend, coworker, who was taking hormone therapy and then did develop blood clots in her lungs. She's probably 55-ish, maybe 56. So I guess I'm curious of what that correlation actually is, and like, maybe that's why it happened, maybe not. But how do they cause and create blood clots in the body?
Go ahead. Jordan, you want to go?
I hear this a lot with patients that'll come in. They're like, my friend, she got breast cancer, she got clots. Essentially, it's really tough because people don't even understand what they're taking, right? So was it progesterone? Was it progestin? Was it actually birth control that she was on? I mean, it's really tough, right? They were told that it was hormones, but what type of hormones? Works kind of on the viscosity of the blood, thickening, things like that on that pathway. But it's always tough when I get those questions because it's like, well, what were they actually on? I have so many questions. Like, was it actually bioidentical hormones or was it birth control that they were on? Yeah.
So people that experience those kind of things with hormones probably have an underlying genetic predisposition. And they probably have some genetic factors that are predisposing them to increase clotting no matter what. And so the estrogen, the testosterone, the progestins, those are going to increase blood viscosity. They're going to increase the red blood cell count. And then you also have to take into account injuries, fractures, sedentary lifestyles, immobility, just different things like that. I mean, somebody traveling across the country, crossing their legs in an airplane, gets off the plane and has a blood clot and DVT in their back of their leg. So, I mean, there's just different things that happen, but most of those people are going to have that, or going to have some kind of underlying predisposition or underlying genetic family, history or problem. I did see a 17-year-old when I was in med school who had blood clots all over her body. I mean, they had a venogram from head to toe, and she had little clots everywhere. I've never seen that since, and it was the only time I'd seen it, and that was from birth control.
Wow. Thank you.
With that, too, I just wanted to add, so he mentioned about the hereditary factors, but there's also obviously a developmental thing with regard to inflammation, this word that's sort of a buzzword that gets used all the time, but that has particular nuance and that it's very specific. But one thing that you will see, and there's emergent science on this, which is why I want to bring it up, is on something called the glycocalyx. So everybody talks about inflammation and what does that mean? But there is strong evidence to show how inflammation actually affects you and how it affects your endovascular system, what's called your endothelium, along with every other cell in your body, every lining of every part of your body. But with respect to blood clotting and heart disease, which, surprise, heart disease is a big problem, right? So this idea of how to protect your glycocalyx, basically the things that make your tissues soft, pliable, and protects you as a barrier between bad things and the rest of you. And that can get broken down, and sometimes what can happen is that if you put too much of the wrong kind of hormone or too much of a hormone into a system that's not ready for it, it can highlight bad things that were ongoing. We don't know their history, right? But that can happen, which reflects back to why you have to see people who do this all the time and who think about this, and back to developing that relationship. Anybody in this room that's ever seen Dr. Reeder or has seen Jordan, you get a relationship. That's the biggest thing that you're getting, and that part is very important and cannot be overstated. That there has to be a strong relationship between you and your provider. You should trust them. They should resonate with you, whomever they are. When they speak, they should resonate with you and how you feel about yourself and your body and your wants and your goals. That's a big part of that relationship, and it's not just that they're there to lecture you or to make you do things. It's that you guys have a symbiotic relationship that helps you feel the way that you want to feel ultimately.
Yeah, and just to kind of go on that, like hormones are, and I always say this, my patients in the room know this, they're just a tool in the toolbox, right? Along with sometimes I will do microdosing GLP-1s, other peptides for patients, but they're just tools, and you have to have that foundation of lifestyle, nutrition, exercise, or otherwise potentially these hormones, could cause issues. So that's why it's so important that every single patient I see, we talk about tools and how it's not a one-size-fits-all approach when it comes to management.
So do you ever use combination oral birth control to help with menopausal symptoms, or is that a big difference between the bioidentical?
I currently do not use birth control in my practice. Dr. Reeder could probably talk a little bit about that.
I don't use birth control pills for the menopausal patient, and I'll explain that in a minute. I do use them in the perimenopausal patient. The perimenopause is the worst time of a woman's life, period, to try to treat hormonally because the ovaries are still waxing and waning, coming and going, in and out of normal function. People can have normal periods and still have low hormone levels. But when we're dealing with somebody with a uterus, the birth control pills are going to give us better control if those ovaries are still coming and going. Once they go through menopause and ovaries have completely failed, I'm going to use regular HRT. I'm going to start them low. I'm not going to slam them. Now, if I've got a 35-year-old that's had a hysterectomy and had ovaries removed, I'll start her at higher doses because we know her estrogen requirements are greater. But at 55, 65, 75, I'm going to start low and then build up based on symptoms. So when you think about birth control, normal hormone levels, and HRT, birth control is up here because it has to suppress the ovarian function to work. So hormone levels are up here with birth control. Normal levels are down here, HRT's down here. HRT is just given in doses adequate enough to treat the symptoms, to make the patient feel better, and to get rid of whatever problem they're dealing with. Does that answer your question?
Yes, it does. I was going to ask something else, but now I forget. And so another question, like when you do start replacement, so such as males that are on testosterone replacement, does that suppress their own testosterone making to where they would really need to be doing replacement forever? Or does your body still make some of those hormones?
It's going to depend on your situation. I mean, I've got patients that are staying sexually active into their 70s and 80s, so why would they stop what makes them feel good? No pun intended on that. But, I mean, there's nothing out there that says that we need to stop hormones when you hit a certain age. Probably all you women have listened to Dr. Mary Claire. She'll tell you, I'm going to take hormones till I die. And she's one of the leading people that's helping educate you ladies. You can come to a provider and you can visit with us every once in a while because of the time constraints, the expense of an office visit or whatever, but you can get online and you can watch stuff every single day and then bounce that stuff off your provider. But there's no reason why a woman can't take HRT unless there's a condition that comes up that says she can't or shouldn't, or that it increases her risk. Take it as long as you want to and as long as it makes you feel good.
Can I go real quick too? Yeah. I always say you have bones, brain, and a heart to protect. So if you want to continue to protect that, you probably want to continue to take it.
So something else, guy or female, I think maybe you were asking maybe for a husband or somebody else, but when you take testosterone for an extended period of time, if you stop taking it, so I've been on it since 2019 because my levels were very low. If I came off of that now, my levels would be very low and stay down there. I'd feel like trash, right? So like once you're on it, for the most part, like you're on it. So if I ever came off, I would always be low, extremely unhealthy, cardiovascular risk disease, diabetes, all those things go up with low testosterone. So that's really the same for men and women, right? Like if you're a female on testosterone replacement therapy from 40 to 50 and then you come off of it, your levels are going to be extremely low. You're going to feel bad. So I don't know if that answers part of what you were asking. Yeah.
My question is kind of on, I would feel like on the other side, because I'm 48, and I've had symptoms, I feel, since my early 40s. I had my tubes tied, and haven't had kids since 39, but I think it feels like it's completely changed, and every doctor, every OBGYN, every single person I've ever saw asking, why am I going through this, or why am I feeling this way? Why do I feel crazy all the time and exhausted, and despite the stress that's in our lives? And yes, I keep trying to find different doctors, but every test that they give me, they just tell me I'm in normal ranges. Well, that's great, but I still feel like shit every day. So as somebody like myself who still gets a period every month, that hasn't changed. I wish it would. Where do you start? Where do you begin? Because I didn't even know this existed until, Amanda said, here, look at this. I didn't know people like you existed. I didn't know anything like this. There was somewhere to go or somebody to see. So as somebody who has never really, this is the first time I've seen something like this, where do you go? Who do you talk to? Where do you make appointments? Because I'm ready.
Right. So Nicole will see you after this, okay? But I just want to add something very, very quickly. So over the years as a diet coach that worked with a lot of females, they were getting their labs and, like no one was hearing them. They had no idea, and I didn't know. So I'm like, well, fire that doctor and go to this other one, right? So then as time went on, that's where I got to meet my team, right? So what I learned specifically for my female clients is those doctors, they just didn't know, right? They were scared. They didn't know. So then you have to find someone that has a very narrow, specific skill set. And that's what these people do all day, you're called the testosterone queen, I heard, right? Like you are very good at what you do. That's what it is. You just happen to, now you know who these people are. But it's all over the United States. There are people like this, and that's really why we started Premier U, for this specifically.
So there's a difference between normal and optimal. Those reference ranges are not designed for optimization. And they're not specific to your age or your symptoms. So unfortunately, that's the healthcare system that we're working with. So it's really about utilizing those labs as a tool for me to look at, but your symptoms mean more to me most of the time than the labs.
If you were to go to 3 or 4 different labs in the area, you would probably see reference ranges that differ from each one. So normal free level in LabCorp might be 0 to 4, and Quest might be 0 to 6, and DLO is going to be something else, and yada, yada, yada. And like Jordan said, there's a big difference between normal and optimal. I had a patient that I was talking to this morning who's a good friend, and that's why I was talking to her this morning. She texted me with a question, and I talked to her, and she said, can you talk to her son, and who's 43 and is struggling with some weight. And I've got this patient on tirzepatide, and she's lost 17 pounds in a few months. Had struggled with weight loss until she got on the tirzepatide. So I talked to Tommy, and I say, you're 43, you need to check your T levels. And I gave him the name of a colleague of mine that takes the male patients. And I said, get your total and free checked. And he said, well, I did a couple years ago. It was a little bit above the low end of normal, and they didn't give it to me. And that goes back to my own experience when I was 49. I'm 62 now, but at 49, I was tired, sitting on the couch after work, falling asleep early, non-productive in the gym, trouble losing weight, losing strength, just didn't feel good. Went online, discovered a colleague of mine from med school was doing a hormone clinic in Tulsa. I called him up. He said, Greg, it sounds like low T. And I said, but mine's 340. It's in the normal range. He said, you're still low T. He said, you're going to feel better at maybe 700, 800, 900, wherever that level is that you're going to feel better. And the only way you're going to get there is to take testosterone. That's what started for me 13 years ago. So big difference between normal and optimal.
I'll just add to that really quick. So this idea of what's normal. So what Greg just shared of 340, this is the only country where that would have been considered normal. Every other country is 350. He would have been clearly within the bounds of that's too low. If you think about, so this is just to illustrate this point. So 4 guys, because this anecdote is hilarious. So if you think about when the normal range got established for guys, it was in about 1998. And the reason that happened is because a drug was coming to market. As most things do, there has to be a value that changes with said drug. I'm not criticizing the process, but that's just how it is. In the FDA office, the story goes, they said, well, you don't have a lab marker to say what's normal and abnormal. I don't know, let's make it 300. That's where it came from. Then the only way that was validated was in a group of young men to see what is normal and abnormal. So that much later, in the early 2000s, several years later, was validated, but in a group of young men, not in the population that tends to need/want testosterone. Many of our lab values are established in a very similar fashion. So that's why there is a massive disparity between normal and abnormal, and those lab values do not get updated. There's no money in that research. Unless something that, like a new drug, comes to market or some very specific reason is present for that to change, it does not change. And it won't change for 40 or 50 years until enough people get pissed or make a big stink about it. Or eventually that, enough providers say, what's up with this? That doesn't make sense. It's not what we see in practice, but that happens very slow. What I like to say, and it's morbid, but it's true, in medicine, attitudes change a funeral at a time. And that's how slow things change. So you can't accept subpar care. You can't accept, well, that I've just told, but I'm pissed, I feel terrible. You don't have to be okay with that. There are other options. It's easy for me to forget that because I live this. We all live this, and I feel like everybody knows this, and I'm just like, where's my megaphone? Let me tell everybody how it could be. But I know that that's not the experience of most people, and that's sad. It's very sad, but that's the truth. And so I get very passionate when we get to do things like this because I know that that's true. I have a wife who's menopausal. Maybe she would kill me for saying that, but I love her. I have a mom who's menopausal. I have a daughter who will become one of these days, hopefully, menopausal. And it's not okay to just have to deal with it or to be told it's normal, this is, welcome to this time in your life. Sorry, it sucks, but deal with it. It's not okay. And you don't have to accept that.
I think if men had experienced this, it would have been cured.
Absolutely. Absolutely. You saw in the movie, right, how many freaking drugs do we have for dudes? Yes. But not enough for females. Exactly. Yep.
She had a question up front too.
Well, she gets ready to ask that question. One of the things I want to point out is there's new research coming. So we are working together with Dr. Bill Campbell at University of South Florida, a good friend of mine, good friend of all of ours now. And he is one of the first people to really research menopause, especially for weight loss and things of that nature. He's spearheading that, and we are working directly with him. So we'll have a lot more, well, research moves slow, but we'll have some new exciting stuff for that coming out.
So back in 2019, I hired Gorman and worked with him for a while. And then over a period of time, he ended up sending me to you. So great experience, but the distance was really hard for me to maintain. So starting hormone therapy with you, it did well for a period of time, but I knew I wanted to continue, and so I started figuring out where I was going to go in my local area. And also my stress levels changed, my environment changed, probably in a good way. And then I was still taking hormone therapy, so it felt like we were having to piece puzzles together to make it work. However, like symptoms were occurring that I wasn't in favor of and liking. So I continued taking testosterone for another probably 2 years. And then I just pulled myself off because my relationship with the doctor wasn't that great. So over time, what can we experience at 37, I think is when I saw you. Now I'm 40. Is it always going to be like adjusting as we get older and age, what the treatment and the dosage will be like? So by the time I'm 48, is it going to look totally different than when I was 37?
Yeah, I think that's a great question. So environments change when patients have surgeries, when they get a divorce. Honestly, I have to adjust medication. So it's not just an age thing, it's definitely a situational thing sometimes, because cortisol plays a role in there too. But yeah, unfortunately, there are patients that are great for like 2 years, and they're like, something's changed, something's off. So it's making sure you're working with a provider that understands kind of your history as well. That's like, wow, something really is off with her. Let's try to get this figured out. So.
And I feel like this is silly, but she invited me, and because Gorman and you were here and it was free, I was like, sure, I'll be there. But I don't really know what Premier U is all about. So can you explain that? And does that mean like I could maybe talk to you again? You know what I mean? So
who wants to take
You want to explain? This is your company.
Yeah.
You
All right.
how our relationships.
Yeah. Want the truth? The whole truth and nothing but the truth. Okay. So Premier U Telemed is we have physical locations, but this entity is capable of seeing patients across multiple states. We've leveraged a good team, including Dr. Reeder, to be able to bring this kind of medicine in a broader place, in a more multi-regional facet. It's a change in how healthcare should be delivered, ultimately. That's another way to say it. We believe that there is a better way to practice medicine, and it requires a lot of work. The reality is that your primary care doctor cannot keep up with this. They see 40 people a day. It's impossible to have a relationship with your patient in the way that it requires to deliver this kind of medicine. I feel bad for them. We have a lot of primary care doctors, OB-GYNs, cardiologists, who are our patients. And I understand that struggle. We understand their struggle. It's basically being able to take those nuances of what you described. This is what's happened to me. This is what's happening in my life. This is what has changed. And to be able to have an inflection point there, to be able to have a relationship with a provider that can make a difference for you despite the nuances of life. I mean, shit happens, right? Things change in life. Sometimes things come up. Our cortisol levels rise. John will tell you exactly how that happens regularly, and he deals with clients doing that as well. So having that relationship, and basically we wanted to bring together and continue to be able to change basically the way medicine can be delivered to patients in a more broad format, and sort of leverage all facets of medicine and not just this very siloed, collimated. We wanted to be able to incorporate nutrition, exercise, peptides, everything that you can think of, supplements, the whole thing. Because your body requires a very nuanced approach. Everybody's different, and you're at a different stage, and everybody's body changes over time too. And so that's the reason why we wanted to have something like this, and it takes multiple brains to be able to do it. And that team is big for a reason.
Do you want me to tell you the truth? So you can handle the truth? So I'll tell you the truth. So Jordan and Brandon are always full of big ideas, and we sit primarily in Swansea, Illinois. And it was actually Jordan that came to me and said, we really need some really great supplements for the patients that we see. right? We were tired of them going to Amazon or Target or whatever and finding it and not looking at the back of the label and understanding what they're taking. They started taking it because they saw someone on Instagram and, hey, I'm guilty of it too. Oh, she looks fabulous. I'll take 3, right? We're guilty of that. And she said, I need to find some good supplements so we can say, hey, when you're looking at protein or what that is, I want to be able to look in the eye and know that this is with their money and for their health. So there was a supplement store in Belleville, and we met the owner of it, and he was great. And he came and he told us about his products, and he's well known in the area, and it was really great. But he ended the conversation by saying, but I'm selling my company. And we thought, well, bump. Okay, great. To who? To whom? Grammar teacher's going to get after me. And he said, John Gorman. And we said, who's that guy? And so, he introduced us, and John came into the office, and I love, when they say great minds think alike. He was singing off the same song sheet that we were. He was tired, just like when Brandon gets so pissed off about traditional healthcare. He's like, people need more. My clients need more. Hey, in Springfield, we have a Whataburger and a Buc-ee's, but we don't have someone like you, Jordan. And we thought we need the trifecta of success, Buc-ee's, Whataburger, and Jordan Kimmler here. And through Telemed, because even though we love Springfield, 2 kids and a husband, she's kind of there, but now you get her through this kind of Telemed world. And we're so excited to work with John and with Leslie and Renee and the whole team because we get to bring that magic here. So it came with just an introduction to him and just having that conversation of, hey, can we dream together and what can be next? And we're really excited and honored to be dreaming with someone like John Gorman.
And two, for me, when I'm seeing a patient, it's interesting when Nicole does the initial intake for me and I'm asking questions regarding maybe medications they're on, high blood pressure, pre-diabetes, things like that. They're like, I thought I was seeing you for a hormone appointment. And I'm like, well, for me, I'm not just a hormone specialist. I literally look at the whole patient. My ultimate goal is to prevent heart attacks and strokes, diabetes in my patients, heart disease, the #1 cause of death in women. I'm very passionate about that. So it's not just about me managing your hormones. Most patients, I even take over some medications otherwise too. So it's looking at medication lists, supplement lists, and also I find that a lot of women are just taking so many things, and it can be very, very overwhelming to stay on top of their protein, to stay up on top of their supplements and their medications. It's kind of, I love to simplify things for women too. So
Where's the microphone? There we go.
I am, kind of. So I'm 35, and mine has to do with the menstrual cycle. I haven't had one since January, and I finally had one in October, but it ran for 32 days straight. And I seen my primary back in August, and she told me that she just thought it was because stress, and I needed to see my OB, but I've not been able to see her until this December. And then it ran for 32 days straight. So I just didn't know, if there's something advice you guys could give me, or maybe I need to get on a birth control, or,
super loaded question.
Yeah.
I definitely can speak with you kind of after regarding some other symptoms. Did your primary care do any sort of labs?
Nothing.
Not even to make sure iron was good,
Nothing.
Hemoglobin stable? Okay, that's lovely.
Yeah.
We need a CPC stat.
I changed. I switched, so
okay.
I got a new one.
Yeah, that's super tough. What's your insulin doing? What's your testosterone level? What are some of your other symptoms that you're experiencing? I think just throwing out, hey, start birth control, I'm not sure if that's the best option, but I need some labs. Thyroid, yeah. Yeah, I need lab work. Okay, so.
And an ultrasound too. You got to consider pelvic pathology, uterine pathology if you're, bleeding all the time.
Yeah.
Ovarian cysts can inhibit ovulation, and you have a stretch of months because you've got a great big cyst in your pelvis.
Okay.
Get a new doctor.
So I would say that that's an issue in itself. Like, it's 3 months out for to see any doctors, and for me, I think I'm kind of a product of the system because I have fibromyalgia, so they put me on things that you wouldn't even believe. I mean, and as for the FDA, for me, after doing research and stuff, it's kind of a joke because it does kind of back those companies that are all about making money, and the FDA doesn't actually do the testing itself from what I've researched. The companies that actually put the product out are the ones that do the testing, and then the FDA stands behind it. So I don't know. I think it's all kind of scary, and I think that if I would have known a long time ago, I would have got me a DO and not an MD. Just because I think MDs kind of mask things and they don't really dig to try to fix the problem. And I love my doctor, don't get me wrong, but what started one, medicine, now I'm on 7. So it's just like, and I do have all the things, I'm going through the menopause, but I still have my periods. And it was weird because it did a switch. I used to never have my periods on time. Like twice a year I'd have a period. And then now I have it every month, but I also have the night sweats and the moodiness and and I'm hurting in my joints. Like I never did that before, so you do feel like a different person. And when I brought this up to my doctor, she's like, well, you're having your periods, so, you're all right. Yeah, it's not.
We treat a lot of chronic pain patients in our practice.
I want you to speak into YouTube is listening.
Okay, YouTube is listening. I treat a lot of chronic pain patients in my practice. So fibromyalgia really should be a diagnosis of exclusion. I do want to throw out the fact we're seeing record high numbers of autoimmune disease. At this point, we have like 110.
Yeah.
So it's all about inflammation, kind of going back to Brandon's conversation. And what we find is when those hormones are not balanced, you're going to have more pain. You're going to have more inflammation. So kind of looking at more root cause for you could go a long way. Looking at your medication list. I love patients when they're like, hey, can you look at my med list? What do you think about this? And a lot of times I won't take them off medication until I start them on some form of hormone therapy. Then we start to wean down, come off of like gabapentin, things like that. I also use a lot of low-dose naltrexone in my practice, which is incredibly anti-inflammatory. Yeah.
So do you guys take most of like the insurances, or is that not? Because my insurance doesn't cover, like things that it should cover.
Sure.
When it comes to anything, that you can fix naturally, like going to the chiropractor, but and that's when I did find a DO because I do have like $1,000. Like insurances are tricky.
Mm-hmm.
Like at first it was covering it, and then I found out there's only so much that they would cover. But I don't know. I think that there's something really wrong with our system.
Absolutely.
I think that, it needs to be more about dieting, health, and that kind of thing, and not, I don't know. I think that there's just a lot missing there because, a pill doesn't fix everything. And so then you end up on more medication and then more problems. And that's where I've been because it's been years. I have complicated migraines. I had seizures as a child, and then I had complicated migraines. And so, I've seen so many doctors, I can't even, and it's sad because I don't want to be that person, but it is what it is.
So what I like to say about myself is that I'm a good balance, right? So I'm not so far functional medicine that I believe you can out-diet, out-supplement everything, including hormones, right?
Yeah.
And I believe we should be utilizing some of these newer tools like peptides and things. So I'm a great balance in between. I understand we need medications at times, and I'm okay to prescribe those. So I think that balance is really what allows me to practice the way that I do, bringing in those lifestyle modifications, bringing in the nutrition. So to go back to your question, I'm also a good balance between insurance and cash. Nicole can kind of go through our cash price to see me, but a lot of your hormone hormones, I will send through the regular pharmacy. Even your lab work, you can choose to use your insurance. So a lot of people that have chronic medical conditions, their deductible is already met for the year. So we will utilize your health insurance to run your labs or any additional testing that I may want to do, like ultrasound, things like that.
Yeah. So do you get to do labs outside? Because that's the way it is for me. Like we have to do Quest.
Yes.
And then it's free for me.
So Quest is our preferred site.
I gotcha.
So absolutely, yes.
And then for me too, I don't think that I could do hormones, and this is why I could never take any kind of birth control because I get headaches, very easy. Smells bother me. Like I'm delicate.
You are,
Yes, you are.
About 20% of the patients that I treat. So I'm very used to having that migraine conversation too. We treat a lot of migraines in our practice as well. I've found that when he talked about the levels of birth control is here versus physiological versus hormone replacement therapy, I find women that could not tolerate birth control and had increased migraines are able to, if we start slow, work our way up, tolerate hormones. Yeah.
Which I have to say, I have started doing Botox, and it has majorly helped me with my headaches. And I'm not in my face, obviously, but but in my shoulders and the back of my head, like, and anyways, it's helped like majorly. So I can definitely see a big change in in things that
we do Botox for migraines in our practice through insurance, actually. So yes,
I just started that, so had one 2 days ago.
I wanted to thank you for that plug for DOs. And if you guys don't know, if you don't know the difference, there's MDs and DOs. We all go to med school. We do our internships, residencies. We get trained out of the same books. It's just a different philosophy of medicine. An MD, allopathic physician, versus a DO, an osteopathic physician. And in simplest terms, I'm going to tell you the easiest way to remember how to differentiate the two. The MD treats the cough. The DO treats what causes the cough. That's a simple way to look at it. The DOs are also taught to be more holistic, that one body part affects another, and that given the right circumstances, the right environment, the body heals itself. So it goes down to philosophy. Now, in current med schools, that differentiation is getting less and less and less, and the programs are getting mixed when they go to residency programs, and there used to be separate freestanding DO hospitals, and you just don't see a lot of that anymore. There used to be a bias against DOs, that they weren't as good of a doctor as an MD. I would challenge that and say they're better doctors because they have a wider range of training and a wider thought process. We're not funneled into a specialty in our second year of school. We go through 4 years of school, and I had a 12-month rotating ship before I had to pick a specialty. So, I picked mine early because I had a passion for it. But there's a philosophy difference, so I wanted to bring that up since you did. The way this model works, and Brandon, you can correct me if I'm wrong, but you asked if you would be able to see me. In this model, that's not probably going to be possible, because what my job is to do is to be the supervising or the licensed physician that the practitioners work under. And I wouldn't have done that if I didn't have the confidence in the product, because reputations for all of us is absolutely everything. Our livelihoods depend on reputation and doing a good job. And if we're not doing a good job, it's going to be reflected by one person telling another. The best advertising is word of mouth. And the comments that I've heard from Jordan in her practice reassures me that she's practicing. You're getting an extension of what I would offer to you. And in your case, when you can't come to Northwest Arkansas and make it a quick trip, then you've got availability. You've got an online resource, which is the direction that's a lot of medicine's going to. Telemedicine and online resources, that's the future. And it's sitting right here and it's available to you. So you may not see me unless you come see me, which, be happy to talk to you about where we're at. We've relocated. The practice has changed since you were there. But you've got Jordan, and you got an online service that's available to you all the time.
Well, and even immediately called and left and was just like, he understands it. He gets it. Like, he knows how to piece together the fitness and the nutrition and the medicine. Like, I knew it immediately. We spent quite a bit of time together that day, and it was just reassuring. So it's nice to know that I could feel confident going and not seeing you, but trust that you're the overseeing physician, monitoring and guiding. So
I'm going to put a plug in for John, because being a client of his and going through the process of on-stage prep and getting up in front of people, I learned a lot about myself and my own dieting and hormones and what I needed to do, because I was that person like you are out in the audience, you know, thinking that what I was doing was right. And when I went to see him and he looks at a questionnaire that he had us fill out back in those days, and he took about 10 seconds to look at it and tell me what was wrong, I knew, I mean, first thing he did is says, "You're not eating enough food." He started feeding me, and in the right amount, and I was eating more food in the proper proportions that I should be, and following my macros, and I saw changes within a week or two. Enough of a change in the first month or two that I went to him and said, "Hey, I want to do a prep. I want to get on stage and prove something to myself." And so I don't want to discourage anybody from asking more questions about hormones. We're available for that. But there's another half of this panel that I'd like to hear from myself sitting up here, and that's stuff that you guys might want to hear about too, and that is the nutrition, the dietary stuff, the workout stuff, the things that happen when a patient like you guys come into my office and say, "I'm eating healthy, I'm exercising, my hormones are right, what's wrong?" Because that's what these guys are experts at, and I'd like you guys to give them a chance to share some of that information, because I deal with that every single day. Somebody telling me they're doing everything right and it's not working.
There's something I want to add real quick. So if you think about this, so we've talked a lot about medicine, right? There's a huge part of this for my client base, it was females, that there was different ways to look at how to go through this. I like to say gracefully, right? The first warning signs. And when you see your labs, like progesterone is typically the first thing to drop, right? So for females, and sleep starts to suffer. Well, on my end, I'm always thinking about things, well, what do we need to do to help maximize those things, right? So there are natural supplements out there that I think everyone should start with immediately first, right out of the gate. Things like chasteberry liposomal to take to get your progesterone levels back up. As soon as you start to see the onset of that, there are things like Cordy's, which, and I'm not up here trying to sell supplements, I'm saying this is the functional side, right, that a lot of people don't hear. All they hear medications, right, and that's what's typically pushed. So on our end, we're also helping people with the supplement side, and that's what Shannon talked about. Like, we wanted to have supplements to be able to offer, because there's a time and place for that right out of the gate. It's not always medication first. So something like Cordy's from New Ethics helps drive cortisol down. And we're all stressed out. Like, everyone's stressed out. We're all working more. We're all on our phones more, stressed out about somebody else is better than me and all this other stuff, right? And we're stressed and we're sleeping less, and our hormones are tanking at an earlier age is what I'm seeing. So when you take something like Cordy's, it helps drop your cortisol down so your body can make more progesterone. It can make more testosterone. It can make more thyroid hormone. So on my end, and Renee, we're pretty much the same up here, what we're talking about. Is we saw our people able to lose weight easier by making sure that we had these things in place. And that's just this huge, huge part of it that it just gets overlooked. It doesn't get the attention that it deserves. Do we have any other questions? I know we've got time probably just for a couple few more questions.
I just had a quick one because we haven't really talked about the cardiac protective benefits yet. And I actually had SCAD a little over a year ago, which led to a heart attack. And I'm on progesterone. Never thought about adding estrogen. Mm-hmm. And would that be something that I should have that conversation? Or is estrogen one of those that now that I've had this event, maybe it's not right? Or are there protective benefits?
I think it's worth an individualized conversation with a provider just to check a few boxes, but I think it's probably a go at this point.
Did you forget it? Yeah, I'll ask it. My question is more of just what are the signs or
points that you really need to start asking the questions, because I'm a mom of 4 kids and one's almost 2, but I'm also 44 years old, so I didn't recognize any of it until I started talking about the brain fog and missing things. I'm like, okay, that is kind of me there. And then you mentioned sleep. I'm like, well, I don't sleep because my kid doesn't sleep. But, you know, what are the factors of that? And then what are some of the diet and the lifestyle? I know you mentioned, John, the core teas and stuff like that, but what are the other things that we can also do along with it all?
So you just said it. As women, we justify things, right? As a normal part of being a mom, a normal part of working full time, stress, right? And I think that it's because that we've essentially been gaslit by multiple providers to feel that way. So progesterone starts to decline in your early 30s. So, you know, we see women actually, it's one of the number one causes of miscarriage, things like that. So, brain fog, I would say, and fatigue are the 2 main ones, and then low libidos maybe somewhere a little bit after that, but mostly sleep too. So I think that's tough, right? Because once again, we just continue to justify things, and that's just the society, unfortunately, we're in. Doesn't mean it's right?
Yeah. So I had this aha moment that I shared with Jordan on the way here as we were driving, because I'm 47, and people who've gone through the, you know, it's like when they say, like, I used to say cool things, and now I say things like, I haven't had a period in 10 months, right? So I'm like 2 months away from like maybe the big M, and I'm 47. And, you know, and we were talking about like, that is young. But when I started to think about this aha, when you think about kids, is that, you know, my very first pregnancy, I had a miscarriage in my 2nd trimester. Right? And so, oh wow. And then after that, I had a difficult time getting pregnant with my first son. And as soon as I got pregnant, they pumped me full of hormones so I didn't lose. So I kept that pregnancy. And then I had a 2nd child. And then I started having symptoms in my early 40s. And whoever said that I started having periods probably every quarter, you know, doing my taxes and having a period every quarter. And then all of a sudden, then it started just to go away. And I said to her, as light bulb moment, I said, I've always been probably hormonally imbalanced. And she said, you probably have. But I didn't know until just recently, like in my late 40s. And because I was on birth control, and they made an excuse about that, is that no one ever took me seriously when I had that is, oh, you have 2 kids, you work hard. Not only do we justify ourselves, but also people justify it for us. And it's time that we stop making excuses and we advocate for ourselves that we deserve more if we're having our period or if we're not having our period, if we have our ovaries or we don't have our ovaries, you have your uterus or not. Hell no, we don't have to do this anymore. So get yourself checked out and maybe get a new doctor, right?
I just wanted to say something else about that. So, you know, this idea that you asked, when do I ask these questions, or when to pursue help? I tell my patients all the time that you know intuitively whether something is right or something is wrong. Listen to yourself. You know, your body knows, your brain knows, your subconscious knows this. If you don't feel the way that you want to feel, there are options. The big part, the reason why we spend so much time learning beyond our formal education, and we continue, it never stops. I tell people all the time, I don't know how much Jordan does, it's probably comparable. I'm at least 12 to 15 hours a week outside of work learning. That's what it takes to be able to do this, to be able to stay ahead of what mainstream is doing. And I would encourage you, if you don't feel the way that you want to feel, if something feels off, whatever that is, pay attention to that and just be in tune to your body, because I feel like that's very important. And also that'll help support your healing journey too. If you are noticing your body and reflecting on how do I feel, it'll help you to have control over it. So you can, sure?
You know, I wake up with brain fog one day, and then the next day, my knees hurt. I
Sure.
don't know. Or
Well,
I had a headache. I mean, it's just.
it is hard, and so it's very complex, obviously, and it goes back to, that's why I keep repeating myself about that relationship and having somebody that you trust. None of us are perfect. Anybody who's ever treated patients will tell you about their failures. I remember my failures all the time. I sort of ignore compliments because I focus on those things and say, I'm never going to do that again. I'm going to get better. I'm going to progress. There's a reason why I learn the way that I learn, is because I don't want to settle for not being awesome at taking care of people. That being said, it takes that relationship and that feedback and you trusting who you see, because there's so many things that, yes, we've talked about hormones, but there's so many other parts of the body that are getting ignored that science has studied. Literature shows what's going on in the body. But again, mainstream medicine, now I won't talk about the FDA, we don't even have to talk about mainstream drugs, but just that pipeline and how those things work, it's tough because drug development takes forever. I say very often, if you only use FDA-approved drugs to treat indications and that's your only framework, you're always going to be 10 to 15 years behind. That's the way that works. It takes $1 billion to bring a drug to market. If it's getting close, you be damn sure they're going to put that thing through and have it be popularized because they have to make their money back. You can only imagine what that system is like. But there are so many avenues. There's so many old drugs, things that have been generic for 40 to 50 years that have really good use cases if you know how to use them. And so that's something that too, as we develop and we unlock certain levels of science and we get new tests and ways to look at cells and how the body works, you can leverage these tools to help in ways that maybe are outside of even standard hormone therapy. There are patients who just don't tolerate it well, or they don't tolerate this or that. Something that works well for their neighbor doesn't work well for them. But that doesn't mean that there's not something else to do. There are, like Jordan said, our toolbox is massive. You just have to be knowledgeable enough to have those tools and know the nuances of when to use them, but also just as importantly, when not to use them.
Okay, we've got time probably for one more. So, and I think we're probably about to run out of the YouTube space. So something I wanted to tell people, and we're going to be around after, so you guys can come talk to people after, but I'm going to tell you something that you can do for free, okay? One's even going to save you some money. If you want to slow down some of the symptoms or going to this even more gracefully, and this is not sexy, and you know what I'm going to say, you have to fucking go to sleep. Like, you have to sleep. You have to. And no one wants to hear that because it's not sexy. Everyone's like, well, I'm busy and I have this and I have that. We all have it. If you sleep less, your cortisol is going to go up and you're going to make more cortisol, less progesterone, less testosterone, less thyroid hormone. You're going to lose muscle and you're going to gain fat, or you're not going to be able to lose fat like you want. You have to sleep. You have to charge that phone 100% every night. You wouldn't charge it 60% and go throughout your day, right? Get 8 hours of sleep. You have to make it a priority. Okay, here's the last one. No one likes this. If you want to speed this up and you want to tank your hormones, keep drinking alcohol. You have to cut that out. And I'm not talking about like people that drink every night, go down to 4 nights a week. I'm talking about, listen, cut it down as much as you can. Because what's it do? Cortisol goes through the roof. It interrupts your sleep, which makes cortisol go through the roof. Cortisol is enemy number one if it's chronically elevated. Cortisol is a great hormone. It does a lot of good things. You don't want it chronically elevated. If you control those two things, they're free. That will help you with so many symptoms and so many things. And my clients hate it when I say that, but they know, I know you're smiling. They know that it's true. So we've got time for one more question, then we can stay after and talk. So go ahead.
Thank you so much. My name is Jen Crosby, and I'm a personal trainer. I want to help my clients that are going through menopause the best that I can. So what are some things that I should be aware of that I can help them the best? Some questions that I can ask, any advice on that?
That question is perfect for you. I was actually going to ask that question. So
I was really hoping I'd get off the hook. Our bodies are different than they were 20 years ago. They're not going to function the same as they were because we're fundamentally different. So you have to have that conversation that you have to train them differently. Perhaps pulling back on their training is going to get them more results than what they used to do when they were 20 years old. HIIT cardio increases that cortisol. HIIT cardio, not really something you should probably do when we're perimenopausal, postmenopausal. So one of the things that I struggle with a lot with my clients who I pull them back, and I told John, because he's my coach, I'm going to fight him like hell when he pulls me back too, because I love the gym so much, but I get it. The mindset of pulling somebody back out of the gym when they love it so much and it is their therapy, to have them shift their mindset to, this is healthier for me, I'm actually going to see results because I'm not pushing myself so hard. Giving yourself some grace, you're going to actually see more results in the gym. So I don't know, I feel like I'm missing a couple of points, but really having that conversation with them. How are they recovering? How are they sleeping? Are they getting sore after they're working out? Because, that's not always an indication of a good workout, but can you pull back on that? Can you eliminate that HIIT cardio? Cardio, maybe it's just, low intensity, steady state cardio where you're just walking. A lot of times that's going to be much more beneficial to someone as they're healing their body as well as making progress in the gym. What I missed? Oh, there you go.
Well, as far as your client is a menopause patient, are they on hormones or not on hormones? So I would definitely start some of that conversation with where's your hormones at? Because there's a big difference in training the menopausal patient that's not on hormones and one that is.
Okay.
Huge difference. And then I'm going to put a plug in. I'm a dude. I'm run on testosterone. You two run on testosterone. There's guys out here. Menopause for men is andropause. And this 50-year-old midlife crisis of stress and family and finances, it's low T. And you guys have men in your life, and there's men in the audience. This is an audience of women. It's for women today. But menopause affects the guys, and their andropause affects you. You got to do this stuff together. One of you can't be optimized and the other one's not. My wife and I, we try to be optimized for each other, right? And you've got access for the guys to use this just as well. So I'd like to challenge this group to have a quorum for men, and you ladies come join them.
All right, so we're going to go ahead and shut this down. If you guys would, please give everyone up here a big round of applause.
So what are we becoming? Where did we go wrong? Yeah, oh yeah, I wanna rise today and change this world. Yeah, oh yeah, I want to rise today and change this world.
All right, that's a wrap. What a blast. That was our very first event, the M Factor Watch Party that we did in Springfield, Missouri, put on by Premier U Telemed, one of my companies. And we had 70 people show up, a ton of people learn from our Q&A panel. And we also had people ask, well, how do I know more? How do I find out more about Premier U Telemed? That's in the show notes. Just check that out. We hope that you guys enjoyed this. We have more content coming soon. See you later.